Visit elmhurst.org to explore the new City of Elmhurst website. Find out the latest Elmhurst news, pay utility bills and parking tickets, report concerns, and much more. Elmhurst.org is an ideal way to discover what Elmhurst offers your business, your family, your life.
Good morning and welcome to Community Conversations. My name is Kathy Jordan and I am the chair for the Elmhurst Commission here in Elmhurst. The Commission provides information and advocates to enhance the quality of life for adults in Elmhurst. What we really want to do is provide you with as much information as possible and educate you so that if you come up with a unique or crisis situation in your home, you know what to do. So today's presentation hopefully will help address those issues. Before we start, I'd like to thank the City Council, Mayor DeCiani, and Pat Dungy, who have helped us and supported us throughout this whole season that we're going to have for Community Conversations. I'd also like to thank Elmbrook Healthcare and Rehabilitation for our treats today. So let's give them a round of applause. I'd also like to introduce our commissioners, because you're only as good as the people you are working with, and I work with a wonderful group of people. Today we have Grayson Haller, who is in the back. Downstairs greeting you, we have Heidi Forbrush and Jackie Haddad. They do a lot of dedicated work and research to try and bring you programs that will be educational and helpful to you. Now I'd like to share with you what our presentation will be. The community conversation will cover an overview of the Affordable Care Act, what has already been implemented and what is yet to come, observed impacts of the law to date and what experts predict if the law is fully implemented. A special focus will be given to Medicare and senior issues. I would like to share with you a little bit about our presenter today, Byron Spencer. Byron has over 35 years' experience in all phases of business and personal insurance, including 10 years managing a large commercial carriers association division with $650 million in premium. In 1988, along with Paul Norman, he purchased the Hyatt, and it's H-I-A-T-T, agency, and formed Norman Spencer Incorporated. Today, Byron remains NSI's president and is active with its various association clients. Byron also serves as CEO of Norman Spencer International Incorporated and is active in all of its programs and operations. Please welcome Byron Spencer, today's presenter.
Thank you. In addition, I'll add 30-year Elmhurst resident, and Norman Spencer International is located in Lombard with offices elsewhere, but so long-time committed Elmhurst citizen and proud to be so. Today what we want to do, I think Kathy set it up very well, is as reasonably as possible go through the what is a monumental amount of legislation and regulation, give you the high points, some of which you will have heard about on television. I am going to try the best I can. I'm a human being and I have opinions and I work in this field, but I'm going to try to present as much as I can on a completely objective basis. I'm going to tell you and I'm going to leave you information where you can find the verification of everything we're discussing today, if you would so choose. I will be quoting a fair amount Congressional Budget Office numbers. The Congressional Budget Office, as you know, is the supposed nonpartisan accounting office for Congress that calculates numbers and promulgates costs and makes expectations of the cost of laws. Well, what made me get interested in this to begin with, and why am I perhaps one of the few people that you will encounter that has actually read this law? It was not by choice, I can assure you. But we did have, when this law was implemented, it came into effect 9/23/10, and we had a very large customer who had over 3,000 lives involved in their health care protection, and their renewal was 10/1. So we actually had 7 days to prepare, if you will, and a few months before to read through these things. And so I actually spent some time going through this thing bit by bit, and I'll tell you a little bit about it as we go along here. You've probably heard it's 2,562 pages of information. Now, this is contained in a Senate bill and a House reconciliation, and the package, and so it's the total pages. By the way, anybody that wants it, I'll be glad to put it on a CD for you or whatever. On kind of an interesting thing, it's also available from the Library of Congress, but of course Congress didn't probably read much of it, and there's a good reason for that in a way. It is not written like a book. The table of contents is 21 pages long, just in itself, and each section is really fairly disjointed. So it will talk about topic A, finish with topic A, and it really doesn't flow into topic B or C or D. And so what Library of Congress did do to help us that have to work with this is they made the form searchable. And so for those of you who might know what that system is about, you literally can put a word in or a concept in and search through those 2,000 plus pages, and it will print out for you all of the sections that might address that. That proved to be a very helpful tool. Now, in addition to this 2,562 pages, many of these sections were very vague as the law was passed, and a great deal of latitude was left up to regulatory bodies, primarily the Health and Human Services Secretary. That would be Kathleen Sebelius today, and the IRS, the Department of Labor, all of these different governing entities. And so over time, since this thing has been implemented, on many of the sections to put forward into full government regulation, there are hundreds and hundreds of additional pages that tell you what those each one of those 2,562 pages says. So we're now talking in the probably 100,000 pages of documentation to begin the implementation of this particular law. The implementation schedule in the law is an 8-year period. We are into that 8-year period now, 2 years. What I'm going to do is go quickly through the past and tell you what already got implemented in 2010 and 2011. In 2010, the changes that I see as significant were the policies and coverage out there for the public was required to have no lifetime maximum. And in the past, most policies had a $2 to $5 million treatment maximum, meaning if you had incurred over those numbers in treatment costs, the coverage would run out. So that no longer exists. I think everybody universally thinks that's a good thing. Now, I will also tell you, having had some pretty severe treatments in my past, it's hard to survive $1 million worth of medical treatment. But at any rate, we think that's a very positive move. They removed what they called annual limits on essential benefits. And a group of folks in Washington, along with HHS, decided for us what was essential benefits. And so what that means is that many policies also had a limit of coverage per year, usually $1 million in that 1 year. The reality is, for these essential benefits, that's no longer permissible, although the government gave out, you may have heard in the press, something over 1,000 waivers. And the waivers were really in this area. And the reason they were there is a lot of major employers of lower compensated workers, like McDonald's, like Burger King, had decent little medical plans for their employees, but they had lower limits. And most of their workers were young and so on, so it really worked very well. And so many of these have been given waivers up to this point on complying with this law. But most everybody else has complied. You probably heard about kids being able to stay on parents' policies until 26. Most policies had a limit at the time of 21 or graduation from college, so this extends that further, whether mom and dad wanted them on their policy or not. It waived pre-existing conditions for kids under 19, and what that means is if you had a sick child, they couldn't refuse, the insurance company couldn't refuse to write them. So in essence, what happened, a lot of that market dried up. They just stopped writing that coverage. But there's other avenues to take care of these issues. You will find as we go along, a lot of things that they intended with the law really haven't come out the way they thought they would. And I think some of the things they didn't have any idea what would happen has gone differently than they might have wanted them to go. The next thing that came into play was 100% preventative care as defined by the government. Now, this is things like your annual checkup, a PSA exam, any of those sorts of tests, male, female, routine annual exam. Now, a lot of policies already covered most of that, but this mandates that all policies have to. Now, this is also the area of controversy that you've heard a lot about. And this is where they have now determined in these hundreds of pages of rules to explain the provisions of the law that they want contraceptives, including abortion, covered as a 100% expense, meaning A, you have to cover it if you're an employer, and B, there can be no deductible or copay involved. And so you've probably heard some of the controversy, and particularly the Catholic Church. And this is not a settled issue. It's ongoing, and I'm sure we'll hear more about that in 2013. Emergencies treated as in-network, to me that was a good thing. Not a big thing, but it was a good thing. You know, everything that gets added, as you can imagine, costs money. So nothing is for free. But some of these things, you know, you might say, well, Byron, should we really force people to buy something they don't want to buy? Maybe some things I don't know, maybe we should. I don't know. Any rate, that is what happened in 2010. In addition, they had a program that they thought was going to get small business people to offer coverage to more of their employees, or for small businesses that didn't offer coverage to start offering coverage. And it was a tax credit. But unfortunately, if you had over 10 employees, up to 25, the 35% credit went to zero. And if you paid the people an average salary of over $25,000, it went to zero as you went to $50,000. So what the IRS reports is that very, very few people took advantage of this, because in essence, for the average person that might have considered it, the tax break was going to be so little bit in comparison to the cost of offering this to their employees when they hadn't offered it before. So this was a idea that I think was a good idea, but it didn't really work out. So very, very few new people were added into the insured rolls. You've heard the concept of grandfathered plans. This was the, you can keep your own plan if you're happy with it. And in reality, that didn't really turn out to be exactly correct, because you had to make all of these other changes that I've already gone over. So whether you wanted to or not, you were mandated to make those changes. The only thing that a grandfathered status really gave you was for certain types of employers where you had some highly compensated folks and there was an imbalance, just getting kind of in the weeds technical, it was good for them to stay grandfathered. It did require that the employer make no significant changes to their plan, and just most of the employers, the overwhelming majority, opted out. However, some insurance companies decided to leave their individual plans as grandfathered status. You know, and as a matter of fact, just along that lines, we have seen growth in what employers are asking employees to pay as a percent of their out-of-pocket and deductibles. So in essence, if they had sought grandfathered status, which really wouldn't give them a lot of reward, they would have lost that flexibility to be able to do that. The next piece really is it created temporary high-risk pools. And the idea of this was to make coverage available for folks that had pre-existing conditions and were unable to get coverage in the marketplace and had no coverage with their employer. And unfortunately, they put rules in that made it necessary that you not have insurance in place for 6 months, and that you demonstrate that you were unable to obtain insurance in order to qualify. Well, any of you that have been sick and been in treatment, you don't have much in the assets left after 6 months without insurance. So this is a thing that, as of last report, which the last report I saw was in like June or July of this year, and at that stage only 45,000 people had taken advantage of this program countrywide. Now, so you'll remember how many ever millions they told us had no coverage. I think I heard numbers from 20 million to 40 million. Only 45,000 have fit this. Now, there is some good news for us in Illinois. Some 18, 19 states had plans like this in place prior to the passing of this law, and Illinois is one of them. And the only problem with the Illinois plan was perennially Springfield didn't have enough money to fund it. And so there would be waiting lines for folks to get in. It was a good program. So what happened is states that had their own plan before were given the option to take the money that the federal government was going to put forward and to put it into their plan. Well, Illinois did that. And I think our plan in Illinois is probably the best in the country. And what I mean by that is if somebody gets laid off from work and they have COBRA and the COBRA is exhausted, the Illinois plan waives the 6-month limit. And so folks can go directly from having a employer-sponsored plan to a COBRA right to the state plan. A lot of people don't know that. And so it probably doesn't affect many of you in this room, but it might affect your children or it might affect your grandchildren. And a lot of people just don't know about it. And it's really a good plan. It's not dirt cheap, but it's not super expensive either. And so it's something that folks should be aware of, and I think a good thing that came from this. Because Illinois' plan is working so well, in the most recent funding, they got the lion's share of the money that the HHS was putting out. So that's a good thing. 2011, was scheduled to begin where the costs that the employer pays for putting your health care on would be added to the W-2 statement and reported to the IRS. The idea was this was not going to create a taxable liability, but I guess one would question, why is the IRS interested in knowing about it if they don't have future designs? Well, it took them a while to get it together, but that was delayed until 2012. And so on W-2s that will be issued based on 2012 income in 2013 now have a box, and if your employer gives you health care, the employer is required to put in what they paid for it. And that is going to be reported to the IRS. There was an intent in the original law to have a long-term care program for seniors. It was a good idea. It was supposed to be voluntary, but have some matching federal funds, and would allow seniors to pay for home health care as needed. And unfortunately, just mathematically, actuarially, it was not a sound plan that they designed, and they really could not figure a way to make this concept work. And so Congress trashed that last year. I don't think they said absolutely they'll never consider it again, but they voided that section of the law. Those with HSA, FSA, these are ways to fund your deductibles and all of that, different government programs. There was some rule changes there. Most significant to you guys is in 2011, it began a tax on branded drugs. And in 2011, it went $2.5 billion to drug manufacturers on brand drugs. And so a lot of these taxes that you'll see that have been implemented into this thing, unfortunately, are being passed on to us. The changes to Medicare started very mildly in 2011. The Medicare Advantage program, how many in here have Medicare? How many have Medicare Advantage? Medicare Advantage, okay, not very many. It's not super huge in Illinois. A lot of states it's very big. And there was some minor cutting to Medicare Advantage in certain areas. Nothing that I would consider significant. I just wanted to remark on it because it did begin in 2011. Some of you may have heard the Part D drug coverage. You've heard of the mythical donut hole. There is a plan in place over a 10-year period to try to phase that donut hole out. And the way that they did it was they implemented a requirement of discounting by the drug manufacturers. Now, you're going to hear several things in here where it's a big penalty to the drug manufacturer, a big penalty to the healthcare system, healthcare insurance. The reason that they signed on to all of this stuff is they feel at the end, or they felt at the end, that they were going to get a lot more customers and that they could spread that cost over a larger base. There's some concern now, well, to date they haven't gotten the customers they expected, and there's some concern that over time they may not. And this will make kind of the whole funding mechanism of this suspect. So just suffice it to say, and it's super complicated, I didn't bring a handout because the handout's too complicated. But basically over a 10-year period, in a very, very typical government way, just know that they plan on doing away with the donut hole. And it'll be a simple, much simpler program for you to administer in your own lives. To me, a good thing. That's a good thing. For 2012, they were supposed to, you may have heard some rumblings about this, but originally the IRS had wanted into this thing a report or a 1099. They wanted businesses to report every time they spent $600 or more to any vendor, including the Office Depot, including payroll services, including anything. And the business community went nuts, and the Congress, in their wisdom, decided to cancel that part of the law as well. 2012 started what's called comparative effectiveness study, council, whatever, and every person that has insurance had to pay $1. It's stepping up to $2 to fund this operation. This is one of the things, there's a couple of things we're going to talk about today, and this is one of them that makes people nervous, because it's a board that's idea is to say what treatment works better than others, and ultimately who should get what treatment, and what treatment does it work for this one or that one. And so there's some concern, some controversy about this. This just began this year. I have seen no output yet. In other words, it's been formed, whatever. I haven't seen anything in writing that they have published yet about what their intentions are. But it is something that, you know, some folks are concerned about. For those that have any kind of voluntary insurance, new law just took effect, matter of fact, just recently, or got implemented just recently, and that is uniform explanation of coverage, that every carrier, everybody has to use the same format for communicating what your coverages are. And it's kind of like little cartoon characters, and, you know, it's, I don't know, just very universal. It's costly for employers to implement, but it's being done, and we'll see what the impact is. So as an employee, instead of going to your employee handbook and looking up what your coverages are, you'll get this thing from the government with cartoon characters that tells you what they are. Minimum loss ratio calculations began, and the idea was to make sure that the insurance industry wasn't having excess profit. Unfortunately, there's been some unintended consequences in that the rules are they have to pay for small business 80% of their premium out in claims to doctors and hospitals and drug providers. For larger groups, they have to pay 85. And so what has happened for smaller groups, where there's some administrative cost at the carrier level, it's had a tendency to cut agents who had, for years, helped and explained coverage to smaller, to individuals and smaller groups, to cut them out of the equation, because their costs were not included in company overhead. And so we have seen you know, a lack of availability of counsel to folks that aren't big enough, so to speak. So this was kind of an unintended consequence. There's a bill being put forward to correct that. We'll see how far that goes. What's coming in 2013? These, again, pre-funding of deductibles will go down. It'll be limited to $2,500 in 2013. There's something called a retiree drug subsidy, and any of you who get drug coverage from your former employer on a retired basis, this may or may not impact you. There was a program when Part D was put into place where employers were giving retirees drug coverage, that since the government was kicking in some money for everybody, that they would reimburse the employer the same amount they were kicking into everybody else. And so it's kind of a complicated calculation, it has been, but in essence, some major employers would get about 35% of the cost back for the covered drugs that Part D would have covered if they didn't provide that coverage to their employees. So because the donut hole is being phased out and they're upping their subsidies there, they're going to do away with that plan. My fear is that employers may discontinue drug coverage at that point for their retirees. We'll see. It's too early to tell, but that does happen at the end of 2013. Medical device tax starts, pacemakers, knees, hips, implants, expensive things. The manufacturers will now have an added tax of 2.9%. You'll see a number of taxes in here, and your one handout I gave you is the 20 taxes that are implemented by this law. And it's also got the page reference on the law that you can go look it up and you can go see it yourself. But the whole idea of this is to take all these taxes and use that to kind of buy insurance for others, was the idea. So this tax, obviously, in my mind, will be passed on to the consumer. 2013 begins the 0.9% increase on Medicare for individuals making over $200,000 and families over $250,000. It also implements the thing you've probably heard a lot about, and some correct and some not so correct. I've seen some scare emails around, but the 3.8% tax on investment income over $200,000 and individual income, our family income over $250,000. This is truly capital gains, an addition onto the capital gains rate. I've seen some that seem to indicate that it would apply to selling your primary residence or things of this nature. And I'm not a CPA, but I don't think that was the intent. Although those that have live on their investments, those that have investment property or vacation homes or rental property, or anybody that has stuff of value, this will hit you because it's fairly easy to get to that $250 if you're selling some assets. So whether your income is there or your capital gains are there or not. The next big thing in 2013 is something called Medicare reimbursement reductions. And what they're going to try to do is a performance-based incentive / punishment for effectiveness of care. Now, when I say effectiveness of care, I mean delivering in the lowest cost, having the lowest return rate. People come back because it didn't work or there's problems. So the idea is the places that offer Medicare patients the best care can earn bonuses. But on the flip side, they can be punished. And so yet to be seen how that's actually going to get implemented. The commission has just started. Again, I haven't seen a lot written about any of the results that they have. So that's something that I think all of us should be watching and keep in our keep in our vision. Now, some reductions that we do know are coming. This is very interesting to me. It's a study on the political landscape that we're in, the I guess the semantics of issues. This is information that comes from the Congressional Budget Office as of July. And they are estimating that Medicare will be reduced, whatever word you want to use, cut, not cut, whatever semantics you want to use. The reimbursement rate that service providers receive will be artificially reduced $716 billion between 2013 and 2022. $415 billion will be reduced from fee-for-service. Now, what is fee-for-service? Fee-for-service is your doctors, okay? That's why a number of doctors have already marked their place and said, if all of this goes into place, we're no longer accepting Medicare patients. I know some of mine have already sent me letters to that effect. So 156 would be in the Medicare Advantage program, 31 in hospital payments, and then 114 from alleged savings from something called the Independent Patient, I just handed it out to you. Help me, I'm drawing a blank. Independent Patient Advisory Council, the one page there. At board, okay? And what these are going to be is 15 individuals that are appointed to terms, and they are going to try to figure out what Medicare should pay for and what it shouldn't pay for, and this is the idea that some have called things that I won't repeat here, but you know what I'm talking about. And the reality is this $114 billion is estimated by CBO at this time that they can save this money. Now, whether that's the case or not, we don't know, but when you hear someone say $716 billion in cuts to Medicare, this is where it comes from. It comes from the Congressional Budget Office. It is their estimate as of July of this year, and it's real. And to me, it's of concern. The big year, 2014, the one that this law has been building toward. 2014, health insurance exchanges are supposed to begin. No longer will insurance companies be able to deny anyone coverage for any health conditions. There will be 3 tiers of plans offered, something along the lines of a bronze, a silver, and a gold. And you will pick one of the 3 plans, and the exchange we'll list all of the players that that's available from, and so that's that. Everybody pretty much has the same thing. At that same time, when those are in place, and I do caution to say we're going into 2013, and right now only 13 states have expressed a willingness to even think about doing this, and none of them have anything ready. If the states decide they do not want to play, because it's very costly to put these exchanges in place, then the federal government is required to have something in place. To my knowledge, that's not in place either. The individual mandate you've heard about, that the Supreme Court just said it's a tax, and since it's a tax, it's okay. That would begin in 2014, and so if you don't have employer-provided coverage, you must buy coverage, or IRS can fine you up to 1% of your taxable income. There will be tax credits available for folks to buy this coverage. Right now, they're targeting up to $88,000, family of 4 income would get some credit. Not clear on where that money comes from, but they would get some credit to buy coverage. Employers above 50 employees would face a fine if they did not offer coverage, and the fine right now is set at $2,000. It later steps to $3,000. Right now, the average employer cost for providing coverage is over $10,000. So a recent survey I saw by Mercer, which is a big consulting company, estimates that 35% of employers will drop their plans. They will no longer provide them to their employees. The tax that I mentioned on health insurers begins, and it starts off at $8 billion, and it accelerates over the next few years to $14.3 billion. The patient advisory board that I talk starts having full authority. It will start meeting in 2013, it will be created, but it will have full authority beginning in 2014. Originally, there was an idea that Medicaid would expand in this law, and they were going to mandate states to do it. And as you may know about Medicaid, a lot of the cost of Medicaid is borne by the states. Well, in the Supreme Court judgment that you all heard about, you may not have heard that the Supreme Court decided that that mandate to states was not constitutional. And so the federal government may not require expansion of Medicaid. Now, when I say expansion of Medicaid, they wanted the current numbers to be increased by 1/3. So they wanted 1/3 more people on the Medicaid rolls. They wanted 133% of poverty to be the new target. You know, this is what's looming in 2014. From 2014 forward, 2016, that 1% penalty to an individual goes to 2.5%. And in 2018, they implement a tax on high-cost plans provided by employers. And it would be a 40% excise tax on high-cost plans. And right now, the numbers are set at $10,200 for an individual and $27,500 for a family. At current trend rates, some actuaries that I have seen have said most plans will probably hit this. This is something that the unions are fighting against because they have very rich benefit plans, and they would be hit with this. And so the member, for instance, of the union, if this came into effect, could have his benefit that he's now reported to the IRS, remember, that's on his W-2 now, taxed an additional 40%. And that would make some pretty unhappy and angry people. So this is where we're at from the implementation of the law. I thought you might be interested in this. This was also in July from the Congressional Budget Office, and this projects the costs of implementing this law. And it's hard to see, but the blue line is what the one on the left is for 2013 to 2019. The one on the right is a full 10 years. So one on the left, 6 years, the one on the right, 10 years. And the blue line is what CBO originally said this would cost in 2009. So that's in billions. And when they looked at it again, I'm sorry, 2010 is the blue. 2011 is the gray. And this year in July is the current. And so you can see that they're saying the 6 years now will be over $1 trillion, and the 10-year jumps up to $1.8 trillion. So tremendous amount of money that we don't have. So a concern to anybody that, okay, where does all this money come from? And it's also troubling to me that every time the CBO recalculates the numbers, they get bigger. You know, I guess that's the way everything works these days. Let me wrap up. This is just personal and anecdotal information from me being in the business. We have seen premium increases since this thing implemented in the 30 to 35% range. And you say, well, why is that? Well, we're being forced as a society to buy more insurance than we were buying before this thing came into place. That's a big part of it. And costs would have gone up anyway. Trend probably would have been in the 15% range or so. So being fair, maybe 20% increase due to the law. I do know one large customer of ours in the first year this was implemented who is self-insured, pays their own claims. They saw a cost increase of $1 million. So this is real. It's not, it's not political. It's factual. One of the concerns I personally have is there is a requirement in the law that I didn't spend a lot of time on to have electronic data. And because of these requirements for electronic data and electronic reporting and patient information, it's forced a lot of smaller physician practices to merge into bigger ones or to be bought out by hospitals. In my personal health here at Elmhurst, every one of my doctors has been sold to a hospital. Everything from cardiologists to private primary care coverage to a neurologist that I had. So I see that as a concern. I think it lessens competition. I have also anecdotally noted, I think, higher costs. On a factual basis, I saw a study this week that says all this electronic record keeping they thought was going to save them money on Medicare. As it turns out, it's increased the amount of billings. Now, why that is, I don't know. The study really didn't say why it was, but it got the finding that they didn't expect. We do have 159 new government agencies and boards and that. I've given you a list on that. We have 20 tax increases in the law. And I suppose the most concerning to me of all, The CBO recently came out with an estimate that says it will leave 35 million still uninsured. So, wasn't that where we started? It's a concern. I do tend to trust stuff that comes from the CBO. It may be tainted a little bit, but you know, I think they're trying to be accurate. And if they think 35 million are going to be left uninsured, then they probably know something. It also, I'll finish with, I think it has the potential to damage Medicare. You can't just willy-nilly cut what you pay doctors and expect them to continue to still treat you. You know, and I don't know, would you expect that? I wouldn't. You know, there's no service provider that's going to work for less money just because the government says so. With that, I'll give you this information. That's how you get a hold of me. And I've got a couple of websites on there that are government websites. There's one called healthcare.gov, and there's another, the Health and Human Services.gov. Both of these have wealth of information. Pardon? It is not. It is not. I didn't put it on the handout. I probably should have. And with that, I'm going to turn it back to our host.
Give Byron a round of applause. Thank you so much for enlightening us. We live in very trying times, very changing times, and we felt this would be an important start to help educate everyone with the complications of what we're all looking at. And it's not just Medicare, but it is all of the United States. So I hope you enjoyed today's presentation. I'd like to remind you that on November 10th, we're going to have another presentation, and I think most of you signed up for it, but you will be getting a phone call. It's called Acting on Your Mind, and it's with Helga and Tony Noyce from the Elmhurst College, and it's about comprehension, problem solving, and creativity. And it covers college students as well as older adults. I always like to end with a little quote. Nothing is worth more than today. So enjoy today. It's a beautiful fall day, and I'm happy that you came to Community Conversations, and I hope you think it's valuable and continue to come. Thank you so much.
Hi, I'm John Quigley, President and CEO of the Elmhurst Chamber of Commerce and Industry. In these challenging economic times, it's imperative that our residents and businesses band together to not only shop Elmhurst, but buy Elmhurst whenever possible. We have great stores in our city center, Spring Road, Butterfield Road, York and Villette Streets, St. Charles and Route 83, North Avenue and Lake Street, along North York and even Grand Avenue. I ask for your help. Let's keep our tax dollars in Elmhurst.